Well, we're going to begin with our first speaker, everyone. Professor Kim Felmingham is the Chair of Clinical Psychology, School of Psychological Sciences at the University of Melbourne, and a proud Hobart girl, I'd like to say. She's a clinical psychologist and neuroscientist who specialises in the field of PTSD. Kim Felmingham has over 15 years' experience in treating PTSD, including treating adult survivors of childhood trauma. Professor Felmingham is recognised for her research examining the neural and biological mechanisms associated with PTSD. Like me, she is an ardent St Kilda fan, so my heart goes out to her. Please make her very welcome as she comes to the stage.
Thanks, Jane, and thank you very much for the organisers for inviting me to speak here today. I'm really delighted that, this is the topic of this conference because it's just showing me how much awareness has changed. In the bad old days, about probably 20 years ago actually, I don't want to think about it, starting in PTSD, there was just such little recognition for PTSD as a mental health condition that affected people. There was some recognition that it might occur within a combat sort of scenario, but not more broadly across different workplace environments and in civilian society. So it's fantastic to see this happen. I will say though, Jane, I think we need a new trauma category, which is being a St Kilda supporter, because that's just perpetually depressing. In that grand final in 2011, I've repressed it. So anyway, so what I'm going to do today is I'm going to talk through, once I work out how to move this thing, is that what I do? Hang on. How do I move my little thing?
Rory's on his way.
Okay, thank you, Rory. That would be good. Doesn't embarrass me at all that I don't know how to use technology. It's quite normal. That's okay, thank you. The big green button. So, what I'm going to do today is give you a little bit of a snapshot about what is PTSD. What actually does it look like clinically as a syndrome, and also then talking about what it looks like in the workplace. I can't be comprehensive about every workplace, but I have sampled particular occupational or workplace settings where we do see particularly high rates of PTSD and exposure to trauma. I'm also then going to talk a little bit about what are some of the risk factors, also what are some of the mitigating factors, and what might we want to do within a workplace setting to try and facilitate people's well-being and mental health. Okay, so really what we're going to cover is, first of all, what is PTSD? So, there used to be quite a bit of controversy about PTSD when it first started as a diagnosis. We have very clear diagnostic criterion for PTSD, and it's a really robust phenomenon. Unfortunately, it's a very chronic and disabling disorder for people who do develop it. So it's no surprise at all the extent of healthcare costs and costs that are involved with PTSD. Once people do develop it, quite a majority of them can actually remain symptomatic for a very long time unless they're getting some specialist intervention. I'm also going to talk about the clinical features, so not just the diagnostic criteria, but also some other associated clinical features which are really important to be recognising and perhaps sometimes we don't think of as part of PTSD as well. We'll look at some prevalence of PTSD across different workplaces, and as I said, those risk and protective factors, and then some basic recommendations about how workplaces can try and assist people with PTSD. And I think that this is, what's also really encouraging, I don't like to just tell a sort of sad, miserable story, is workplaces really are embracing this and recognising this, and there are a lot of newer strategies that are taking place to try and work in this area to improve mental health. Okay. So, PTSD is one of the most common psychiatric disorders that can develop after experiencing a significant traumatic event. So, About 70% of us actually in our lifetime will experience a significant trauma across the span of our lives. I personally have had about 8 car accidents because I'm not a very good driver, don't ever get in a car with me, so thankfully I'm not driving up to Launceston tonight. But of those 70% of us, only about 10%, maybe 15, are going to develop PTSD. Okay, so already fundamentally we've got a resilience story here. That most people, the norm is that they're actually going to be okay and be recovering after having a trauma. However, what we also know is that repetitive, cumulative exposure to trauma significantly increases our risk of developing PTSD. We also know that there's people in particular work settings who are significantly more exposed to traumatic injuries and also to these repeated traumatic events just by the nature of their work. Okay. So first responders. So we've got police, paramedics, firefighters, rescue personnel, SES. So we've got to think about volunteers as well as people who are employed in these professions. Journalists often are also people who may actually be first on scene at times. Journalists actually get very little training in managing trauma and managing critical situations. Transport workers, defence personnel, forensic personnel, so correctional officers, as well as people working in the health professions, so psychiatric nurses, people working in emergency settings. And we know increasingly there's reports in the media about an increase in physical abuse, in verbal abuse of health workers on the front line, paramedics, police. So we really are recognising now, and it's not just a once-off trauma, it's also that repetitive, cumulative nature of it. And we know that that cumulative trauma exposure is a risk factor for developing PTSD. We also know that it's a risk factor for developing depression as well as substance use, typically as a way of trying to cope with some of these psychological symptoms. Okay. So, the other sort of point I want to make is that when we have a trauma, it's not just PTSD that can develop in terms of psychiatric conditions. PTSD is one of our most common psychiatric conditions that develops after trauma, but equally we can see as high rates of depression developing after a trauma. Also other anxiety disorders like generalised anxiety disorder. I've put that resilience story in. Oh no, I've found the green button. Sorry if anyone has a tendency to epilepsy because I get excited and do this, so I'll try and restrain myself. But yeah, there's a resilience story, but depression, anxiety disorders, substance use disorders and PTSD are all very common after a trauma. So I think that's something really important we need to keep in mind. Sometimes we can get PTSD blinkers on and we're just looking for PTSD after trauma exposure, but we need to be thinking more broadly about some of these other psychological conditions. Okay, so what is PTSD though? How do we define it? How do we diagnose it? So in Australia, if you see a psychologist or a psychiatrist, typically we use the DSM-5 is what we use to actually diagnose PTSD, which is a standardised list of a range of symptoms that then if you meet criteria for these symptoms, you can actually receive a formal diagnosis. The ICD-11, we won't get into this debate, oops, I'm going backwards now, but Europe has a different diagnostic system and there seems to be a few divergences happening there which will be a little controversial, but in Australia we do use the DSM. So what the criterion are, first of all, is importantly that you must be exposed to a significant trauma. Already that's a controversial area. How do we define what a traumatic event is? When I'm doing my research, and I'm saying, look, I'm interested in people who've experienced trauma. I got a man ringing up who'd been retrenched from his job, and it really genuinely had been a life-shattering experience for him, but it wasn't what we classify as a trauma in terms of PTSD. Okay. So how do we define what a trauma is? It is basically an event where you've either witnessed death or you've experienced threatened death, actual or threatened serious injury, or actual or threatened sexual violence. Now, that trauma can be experienced in the following ways. You might have had direct exposure yourself to that event. Or you might have witnessed that trauma happening to somebody else. Or you might be there in the aftermath of trying to manage that traumatic event. You may also be learning of a relative or close friend has been exposed to that trauma. Now, that's a little bit of a grey area. You know, if you're expecting a relative to die from a terminal illness and then you find out that they have and it's been expected, yes, you're going to be very sad and have a grief reaction, but that's not necessarily trauma. It's more when you're receiving a phone call and you're hearing of someone who's had a sudden accident or been in a really severe car accident and you get memories of getting that phone call. That's the kind of scenario we're talking about there. Also, though, importantly in DSM-5, they've really recognised now that there's persistent indirect exposure to aversive details of trauma, usually in the course of professional duties, can also be considered a trauma. So what they're thinking about here is police officers who are needing to look at image after image after image repetitively, maybe of child pornography, or hearing details of sexual violence, or having to attend multiple sort of fatal injuries. But it's not just attending these events, it's also being exposed to stories and images of trauma as well. Okay, so that's, first of all, to receive a diagnosis of PTSD, you have to have experienced a trauma of that type of nature. The re-experiencing symptoms are typically where our mind is somehow replaying or reliving the trauma. So very commonly people with PTSD report having distressive, intrusive memories just pop into their mind or being triggered by things in the environment. And they are really, really intensely distressing. People are trying to block them. Also, they might have nightmares about the trauma, flashbacks about the trauma, and they can range to just briefly having a very intense image where you lose awareness of where you are, but they also can be where you're really losing conscious awareness of where you are for a period of time as you're really experiencing, feeling like you're back in that traumatic event. There's also intense or persistent distress to trauma reminders, as well as physiologic reactions to trauma reminders. So to meet criterion for PTSD, you need to have had at least one of these symptoms across a month's time frame, okay? So the next criterion is avoidance symptoms, and these typically where people are avoiding thoughts or emotions that are associated with the trauma. So if these intrusive memories are coming in, you're trying to block them. You do whatever you can to push them out. This is often where people might use substances to try and reduce feelings or emotions or thoughts. But dissociation can also occur here. I had one client who put on really, really, really loud music to try and get those images out of his head. So it's a very natural coping mechanism. You don't want these images or these memories in your mind, so you're trying to block them and push them out. Also avoiding situations, activities, people, places that remind you of the trauma. Okay. So again, you must have at least one of these in the past month for a diagnosis of PTSD. We have, the next category is negative cognitions and mood. So some people, which can frustrate police officers if they're trying to get a really good witness statement, but sometimes with PTSD people have an inability to recall salient aspects of the trauma. So, you know, someone who's had a hold-up might be able to report some details, but they may actually be blocking the memory of the assailant's face. Okay, so this can happen, it's called psychogenic amnesia. Also, people can have overly negative thoughts and assumptions about the world, and this has to have changed since the trauma. So it might be about the world, it might be about themselves. So suddenly they start thinking the world's unpredictable or it's unsafe. I've got to be constantly on alert, something bad might happen. Or they might start to think, I'm weak, I'm pathetic, that I can't cope with this, okay? It's a very common type of thought that people have associated with PTSD. They might have exaggerated blame of self or others about the causes or consequences of the trauma. There's also a lot of negative affect. And what's important here, it's not just fear that can be an emotional reaction as part of PTSD. People can also experience significant levels of anger, guilt and shame, And that even might be the most prominent emotion that you see in someone presenting with PTSD, more than fear. Often people have a reduced interest in activities. They might feel alienated and withdraw from others. So there may be some detachment, isolation or estrangement. Often people feel like no one's understanding what they're going through, and they may have struggle with trusting others to tell people what's happening. Many people feel difficulty experiencing positive affect, so they have a restricted range of affect, like really just blunted happiness or joy or love. And people often don't associate that with PTSD. That's not a symptom people talk about. So if that's happening to you, if you've got your child running up to you and you give it a cuddle but you don't really feel much love, you can then start to interpret, there's something really wrong with me, I'm a bad person, you know, because I can't even love my own kid. And all of this is not expressed to anyone else. Most people with PTSD are not going around talking about these symptoms. So therefore, people can start to blame themselves for having these symptoms rather than understanding it's part of PTSD. So again, everyone is very different in how they present with PTSD. You need to have at least 2 of these for a formal diagnosis. But again, some people, you know, and so there'll be a different pattern with different people. Some people are going to have really extreme intrusive symptoms and re-experiencing symptoms. Others are going to have really extreme avoidance symptoms. And the pattern of these is also different. The final category is hyperarousal symptoms. And so here we've got things like increased irritability and anger. We've got risky or destructive or reckless behaviours that can occur. Hypervigilance is a really classic sign of PTSD, and that's classic where people are on the alert for danger. You know, so someone might go out for dinner but they're sitting with their back to the wall so they can scan the room, all right? So people are constantly looking out just in case something bad happens. Now, in some operations, especially in defence and the police, you're trained to be hypervigilant anyway, but PTSD can exacerbate that hypervigilance even further. So you're still remaining vigilant even in objectively safe situations that you wouldn't have been before the trauma. There's an increase in startle response. In fact, I had one police officer I treated for PTSD. He was fantastic. He did so well in therapy that he then tried to recruit all these other police officers. So what he'd do is go to lunches with ex-police officers and he'd walk up behind people and slam the table behind them, and anyone who jumped, which is showing a startle response, he'd be in their ear relentlessly that they had to come to this treatment program. I think he recruited me about 10 or 15 people. It was fantastic. Anyway, also we've got impaired concentration and impaired sleep, and sleep disturbance is really significant. It's not unusual for someone with PTSD to report only getting about 3 hours of sleep a night. And often that's very broken and fragmented sleep as well. We now think PTSD is not, sleep disturbance is not just a symptom of PTSD. It might actually be an etiologic factor. So it actually compounds the mechanisms that keep PTSD going and developing. So again, really important to assess for that and examine that. You know, oftentimes in some of these professions where people are exposed to critical incidents, they're on shift work. So that sleep fragmentation there, just by the nature of the role, is also going to compound the risk for developing PTSD. So you need at least 2 of those for a diagnosis as well. So this is the DSM-5. You need, these symptoms need to be occurring across the past month to get a diagnosis of current PTSD. They also need to cause significant distress or functional impairment. And these symptoms can't be explained by other issues like medication withdrawal and so on. Now, there's also really important clinical features to highlight those. So whilst PTSD often is characterised by fear responses, in a substantial proportion of people, there's actually a numbing response. There's actually an absence of fear, all right? So if someone's presenting with PTSD, they may not be presenting with really excessive fear and panic attacks. In fact, they might be presenting as numbing out or really, really angry, okay? So we've got to think beyond fear for the range of emotional responses that might be there. So PTSD can be characterised by numbing, anger or dissociation, rather than a predominant fear response. As we noted, there really is significant individual differences or heterogeneity in what pattern of symptoms they have. So it's not like everyone's going to present with the exact same symptoms, so we can go, yep, that's PTSD, that's not. There is a lot of variation in how people present. High levels of comorbidity are also found with PTSD. So depression, substance use, and pain and other anxiety disorders are really commonly co-occurring with PTSD. So I think really highlighting guilt and shame can be really important features that are associated with PTSD. Anger, certainly, and we see that particularly, there's high rates of anger when we're looking in police officers, in Defence Force as well, so we need to be considering anger. Anger also can influence how people are responding to treatment, so it needs to be addressed. Distrust of others and impaired emotional engagement. And this can lead to significant relationship difficulties with maintaining work and working in a team can be problematic, as well as substance use and dependence. So, we now have increasing recognition. There are high rates of repetitive trauma exposure in particular occupations. So these are some in Defence Forces, as we said, in first responders, in journalists, health and wellbeing sector, train and bus drivers, people involved in transport, and also there's commonly industrial accidents on sites as well, and also in a forensic setting. So this is just a national review, which was really large scale, was conducted by Beyond Blue last year, into the mental health and wellbeing, and this is in police and emergency services. So this graph is just telling you wellbeing statistics. So the darkest bar is people reporting high levels of wellbeing across the different professions: ambulance, fire, police, SES, and total. And this is compared with a sort of national representative sample. And it's scary to see what amount of people are actually reporting high levels of wellbeing. This is people with moderate levels of wellbeing, which is good that that's the majority. But people with low levels of wellbeing are really quite a considerable number. We're up around 30% on average there. This is now looking at prevalence rates of psychological distress across occupations. And so we've got first responders, then we've got the ADF, and then we've got the general population in Australia. So what you can see here is this is high levels of psychological distress, and then this is very high levels of psychological distress. About 25% of first responders are reporting high levels of psychological distress. Around 8% in Defence Forces, and that's equivalent to the general population. And around 9% of first responders are reporting really very high levels of psychological distress. 39% of employees and 33% of volunteers are diagnosed with a mental health condition, compared to 20% of all Australian adults. So it's really importantly highlighting that there are really significantly elevated rates of mental distress in first responders relative to the general population. Okay, so what about the nature of trauma exposure? So this is just telling you percentage of physical assaults and verbal abuse, again in first responder professions. So you can see again there's around 25% of people in first responders reporting physical assaults, which is just mind-blowing. And in fact it's probably an under-reporting estimate there. And 28% are reporting verbal abuse. Okay, around 13% of paramedics here are reporting physical assaults. And again, I think there's more and more highlighting of this happening in the media, and it appears to be increasing, but whether that's just that the reporting is happening more, we don't know. And again, 18% are reporting verbal abuse in paramedics. So, if we now look at prevalence of PTSD, so this is across the SES, ambulance, fire rescue, police, ADF, and then this is our general population. What you can see here is on average about 10% of emergency service workers are reporting PTSD. And that's using PTSD screeners that are validated instruments. So higher rates of PTSD and depression, interestingly, are also seen in people who've retired 5 years ago in emergency services, and that's actually higher than current serving members. So I think that's something important to highlight too, is after retirement these issues don't go away. In fact, they might potentially escalate. And whether that's to do with loss of role and loss of social networks and supports, that's a reasonable hypothesis to have, but we don't have the research around that yet. Another thing I think we need to think about, there was one meta-analysis that reported there was higher prevalence rates of PTSD in paramedics than firefighters and police, but I think we also need to think about there is a significant likely under-reporting issue because of stigma in these professions about having mental health conditions. Many people are reporting being fearful that they may lose an operational role, or that they may, their employers may lose confidence in them if they're reporting having these mental health conditions. Okay, so the clinical presentation of PTSD in emergency service workers, generally you're seeing some of those same symptoms and diagnostic criteria that we see in the general population. However, emergency service personnel often respond to trauma events with more anger and guilt than the general population. So that seems to be elevated more in the clinical presentation. And substance abuse, again, is elevated in emergency service personnel. Being trapped in dangerous situations and assaulted by others are particularly significant predictors of PTSD in firefighters. And also, as we said, we've got to consider the impact of cumulative trauma in this population. And often what you see with cumulative trauma is a marked increase in those hyperarousal symptoms. So the irritability, the poor concentration, the sleep disturbance and hypervigilance are actually really elevated, particularly when you get repetitive cumulative trauma. Another important point is many may experience significant subsyndromal PTSD symptoms, so they're not actually getting the formal full diagnosis, but that doesn't mean they're well. Oftentimes they may actually have some significant symptoms, but it's just not quite getting them over the line for a diagnosis. Now, those people are still important to intervene with and to support and try and assist, because what we know is if you've got subsyndromal symptoms of PTSD, you're more at risk then of developing full-blown PTSD if you're having further traumas. Okay. All right, so this is just a snapshot of, journalists with trauma exposure. So I'm just going to quickly go through a few other professions as well. Now, this is in war correspondence, but you can actually see the percentage of journalists who are actually attending really significantly traumatic events. So injured or death of children is one that just gets to people. You can't keep up that professional guard or that distancing that you need often when you're dealing with children in a traumatic situation. And so 97% of journalists were actually reporting attending these types of scenes. You know, also assaults, murders, other gruesome scenes are all in the high 80s, the 80% of people. These journalists are often first on scene, as I said. They're not trained to deal with trauma or emergency situations. Others remain, and they often remain engaged with the scene for quite a long time after. They're having to interview people about the aftermath and how they're coping and so on. So the rates of exposure to trauma are very high. Also, there's a difference in domestic journalists and war correspondents, so between 4 and 13% reporting PTSD in domestic journalists, but around 30% of war correspondents presenting lifetime PTSD. And the clinical presentation is there's a lot of intrusions and re-experiencing symptoms particularly. Okay, drug and alcohol workers again can be exposed to verbal and physical assault from clients, but also indirect trauma from hearing trauma stories of their clients, because typically people who are clients in drug and alcohol services have really extreme levels of trauma. So a recent study found about 19% of drug and alcohol workers actually have secondary traumatic stress syndrome, which is actually developing PTSD from hearing these trauma stories. And this was associated with having a higher traumatised client workload, fewer hours of clinical supervision, and stress and anxiety. So it's highlighting the importance of organisational factors. Your caseload and whether you're getting good supervision are important here. Also, if you have a personal trauma history and your work and social support level are really important to be considering. Correctional officers, there's fairly limited research here. One US study found equivalent rates of PTSD in correctional officers to Iraq and Afghani war veterans. Approximately 19% had probable PTSD. Another actually found around 34% of people had PTSD. In New South Wales, correctional officers were actually found to be the occupational group with the highest stress claims and rates of alcohol and other drug dependency. So again, looking at the rates of trauma exposure, about 25% received a threat to self or family, 50% witnessed a fellow prison worker being injured, 50% witnessed a death of an inmate. And again, the vast majority were dealing with the aftermath of sexual assaults as well. Psychiatric nurses, again, have high rates of exposure to verbal and physical assaults and high rates of ongoing occupational daily stresses. And we know that that actually is a compounder for developing PTSD. If you've got low resources, you've got to do double shifts, you've got a lot of stress and not enough support around you in the work environment. 73% reported a physical assault in the past year in one study and 18% met criteria for PTSD. Other studies are reporting PTSD around 10%. So what is the impact of PTSD in the workplace? So it can lead to memory and concentration impairments, physical problems, fear responses, difficulties interacting with co-workers. Absenteeism, of course, is increased if people have PTSD. Sleepiness, pain, there's a higher likelihood of unemployment or underemployment and lower pay. What are risk factors for workplace PTSD? And this is in first responders. We do know from a lot of research that there are some sort of individual or personal risk factors for developing PTSD after a trauma. So if you've had previous trauma exposure or you've got a previous psychiatric history, then you're more likely to develop PTSD after a trauma. It's not guaranteed, but you've got an elevated risk. If you've got poor or low social support or a family psychiatric history, there are also risk factors. The nature of the trauma exposure also gives us some particular risk factors. So, as I said, that cumulative exposure to trauma, repetitive trauma, the idea of that stress bucket, we've all got a stress bucket that has a finite limit and then it's going to overflow. So the more traumas you have, the higher that stress bucket is going to fill up. Okay. Also, another risk factor in the moment is if you are unable to use your distancing. So anyone who's worked with first responders or police or emergency workers or paramedics, there's a very dark sense of humour, there's a black sense of humour, and that distancing, these ways of trying to cope. But if you have to attend a scene of a child or there's some other personal element involved, then that can undercut your coping mechanisms and that can increase your risk for PTSD. I had one client, a police officer was attending a fatal accident and the car was the same make of car as his son's car. And as he was on approach, he was thinking, God, is this my kid in here? So he just couldn't use those same distancing mechanisms. Perceived threat during trauma and also paramedic, if you've got significant distress afterwards. Perceived responsibility of things you did or didn't do at the time. Often you're having to make decisions in the moment with critical time sensitivity. So oftentimes in hindsight people can start to blame themselves about what they did or didn't do. And also poor social support after the trauma is really critical. Routine operational stresses are also important risk factors. So shift work, fatigue, time-critical responses. If you perceive lack of control or autonomy over the situation or over the decisions you're making, if you have a lack of training or role clarity or poor employment security, they are all risk factors for increasing PTSD. And so organisational stressors are important to consider. Management, supervision, leadership, morale in the collegial environment, role clarity, adequacy of resourcing, and also lack of time given in the aftermath for you to be able to deal with the event. All right. So, level of perceived support after trauma is one of the strongest predictors of PTSD, so low levels of support. And also the amount of concurrent life stresses. So the good news story here is that gives us a pathway to help mitigate the risk of PTSD. If you can increase the level of support, give people time to be able to deal with the trauma, create a workplace environment that's going to provide support and mental health care. So, workplaces that had the lowest levels of psychological distress and higher resilience provided sufficient time for people to recover from trauma. There was lower levels of gossip, stigma and bullying. So the workplace culture can either compound or buffer the effects of trauma. In workplaces with higher rates of PTSD, employees were less likely to have time off, reported lower support or opportunity to talk, and reported emotional exhaustion that was affecting their private lives. This is a study where they're basically mapping the number of fatal events attended in firefighters, then the rates of PTSD, depression and heavy drinking. So you can see there is a clear, linear, significant association. The more of these events you attend, the higher your rates and risk of developing PTSD, but also depression and also substance use. So this sort of goes against the idea. I think there is an idea, look, if you've attended lots of events and you're still okay, that means you're resilient. But actually this speaks against this. This suggests the more events you attend, the higher your risk is actually going to be. So we shouldn't be just going, oh, you're okay, you're resilient, because that may actually be not recognising a developing issue for someone. Okay, I'm not going to have time to read through the lived experience, but I think, these are some scenarios from the Beyond Blue report. Really, if people are interested in it, it's a really good document to read, just giving voice to the types of experiences people had. This first person, her first day on the job was for the Black Saturday bushfires. And they had to decide to send people down from New South Wales to Victoria. She sent someone down who was a friend of hers who was subsequently killed. So these are the kinds of experiences and events people can have. So important themes to consider regarding trauma in the workplace, personal relationships. And I think this is really important in a place like Tasmania, your smaller regional or rural communities. What about the personal connection of people who might be involved in the trauma that you're attending? But also, what if other colleagues are suiciding or have got really significant health injuries or are injured in the traumatic event? So we need to start to think about if there are those personal relationships, there's a really elevated risk. As we said, the inability to use distancing mechanisms, perceived responsibility, and that can lead to guilt and shame, which can really compound trauma. The organisational culture of just snapping back in, you've got to be operational, we're in Superman mode, is really very significant in terms of increasing risk. And I think that's where we've got to work against the stigma of actually putting your hand up and going, hey, I'm actually not dealing with this. And, for that to be okay in a workplace culture is so important so people actually can access support. As we said, the cumulative and repetitive trauma, shift work is a really important factor to consider. It's already mucking around with sleep and often relationships and capacity to get support. Sudden transitions. So, one moment you're at home having dinner and the next you're out at a trauma and then you've got to come back home again. So you're switching contexts and that can also compound that feeling of I can't talk to anyone, I can't manage this. And not having any downtime, especially if you're under-resourced. I mean, some of the shifts that people are doing, or doing back-to-back shifts, is incredible. And again, that's going to compound the trauma. So the risk factors in military populations, again, really relating to the length of time of deployments, how much active service, how many traumas you're experiencing within that. If you witness someone being killed, if you've discharged a weapon, deployment-related stressors and poor post-deployment support. So again, some similar themes coming up for risk factors of PTSD. Risk factors for journalists, interestingly being a parent has come out, which I think is again speaking to that vulnerability of managing if you're seeing trauma involving children. The length of career, the extent again of the exposure and poor social support. So consistent themes again coming out. I won't go into that just in the interest of time, but role of stigma I want to highlight because I think it's really a significant issue. So what's encouraging is most employers recognise the importance of mental health. Most of them actually report that they can actually see their workplaces are trying to assist, but there's still this fear on an individual level of then reporting. So even though they recognise the importance of mental health, we've got a way to go for people to start to recognise, actually, I need to get some help for me. There's still a fear of losing that ability to work in that operational role, or that there'll be adverse career consequences. Okay. So also 33% of employers felt they needed support for their mental health condition. What was a good news story, of those 75% sought report, 47% felt they received sufficient support, so we've got a way to go in that. 35% felt they didn't receive sufficient support for their level of mental health issues. The most common type of support was formal or informal debriefing with a manager or colleague, and 50% sought counselling within their organisation. 15% of people who had very high levels of mental distress didn't feel they needed support or recognise they had a mental health issue. So there's still a mental health literacy problem that we have as well. 20% of people with PTSD perceived a need for support but didn't seek or receive it. And often there was a delay of about a year before people actually sought support as well. Compensation processes. Most people, only 14% made a compensation claim for mental health conditions from this Beyond Blue survey. 61% felt that it had a negative impact on recovery and felt that they weren't supported through that process. So I think, again, we might need to do some more work there. So, recommendations. What do we do for managing workplace trauma? And Andrea is going to be talking a lot more about this, a lot more intelligently than I am. But as poor support is a critical predictor of PTSD, it's vital we're developing a supportive organisational culture, especially if we are in organisations where we know our workers are going to be exposed to repetitive, cumulative trauma and critical incidents. So vital we reduce the stigma and increase support for mental health and wellbeing, and also giving guidance on managing trauma, having that at a policy and procedure level in our organisation. Recognising the significant impact of cumulative trauma, encouraging discussion and recognition and value of mental health. Minimising shift work if you can, or disruption, but also under-resourcing and looking at that and how it might affect people's wellbeing. Minimising daily occupational stressors, developing effective screening measures for PTSD to facilitate early intervention. Avoiding single incident critical stress debriefing. There is evidence now that that is not an optimal methodology to manage trauma. In fact, the nature of it is if you're forcing people to disclose about the trauma, that is not helpful. In fact, it can be, some evidence suggests it may potentially be harmful. A better way is to just educate people, normalise, give them information about what reactions they might have about trauma, and if they want to talk about it, then they can with someone, is a better model. Allowing sufficient time and role flexibility to enable the employee to deal with trauma and facilitating resuming those occupational roles. Anyway, I'm going to finish up there. I think I've droned on for long enough. So thanks for listening and, enjoy the day.